Otitis media with effusion, OME, also called secretory otitis media, also known as glue ear. When to put grommets? Otitis media with effusion is a condition where fluid accumulates in the middle ear of children, usually because of frequent colds, adenoid enlargement, or eustachian tube problems, eustachian tube blockages, sore throats, tonsillitis, chronic coughs, etc. When the fluid accumulates in the middle ear, it is usually a sterile collection of fluid, and because the fluid dampens the movement of the tympanic membrane or eardrum, the child will typically complain of impairment in hearing and blockage in the ear, like after a flight. The assessment of OME is done by your ENT specialist by checking your eardrums and by doing simple tests which are age-appropriate audiogram tests to check for the hearing of the child, and an impedance or an impedance tympanometry test to check for the compliance of the middle ear, to check for the movement of your tympanic membrane, to check for fluid built up in the middle ear, as well as if there is any negative pressure. Once these reports are compiled, your ENT specialist can tell you about the presence of otitis media with effusion, and sometimes there is a requirement for surgery. The requirement for surgery is usually if a child has persistent hearing impairment, if there is otitis media with effusion for 3 months or longer, and if we find that there are difficulty in the child maintaining concentration in class and has a problem doing academic activities. There will also be some amount of social changes in the child. There may be less amount of peer group interaction and other intellectual and cognitive impairment if secretory otitis media continues for a prolonged period of time with a hearing impairment. Otitis media with effusion is usually treated with a grommet insertion in the following conditions: persistent otitis media, occasional pain in the ear, persistent impaired hearing in the child, impaired hearing causing disturbance in academic or social environment, and any other reason that you may think of at the time when the ENT specialist examines the child and feels that a surgery may be the best option for the child. Sometimes we perform this surgery to prevent future complications, particularly retraction of the eardrum in chronic cases where we feel the eardrum is getting thinned out and getting pushed inside towards the middle ear. To prevent any future cholesteatoma formation or any other complication, the ENT surgeon may advise grommet insertion. A grommet usually causes immediate relief in the hearing of the child. Fluid is sucked out. The grommet stays inside for about 3 to 6 months and usually extrudes spontaneously. Sometimes a grommet may have to be removed by some procedure, and sometimes the grommet may continue to stay persistently. Sometimes the grommet may remain inside for a long period of time, in which case it may need to be surgically removed. One of the complications of grommet insertion is that there may be a residual perforation once the grommet comes out. Usually we will request you not to let the child swim, but that decision can be earmarked to the condition of the child and can be mutually discussed between the ENT specialist and the parent to decide on what is the best course of action for the child. There is also a differential diagnosis in the formation of secretory otitis media or ASOM, and the most important is to rule out congenital cholesteatoma and other middle ear malformations which could cause a similar problem of hearing impairment or a sensation of blockage in the child's ear. A grommet insertion can cause practically immediate relief in a child who has a persistent secretory otitis media with conductive hearing loss. There may be other indications also which your ENT specialist can discuss with you.